Welcome to this video. My name is Cornelia Barth, and we are going to talk about reinventing rehabilitation research, or what up-to-date rehabilitation research and research needs for challenging contexts of low resources, conflict, or disaster have in common, and what not. A literature research on rehabilitation in low-middle income countries reveals three facts. 1. You quickly note that your search results show a huge blank. There's a very obvious issue with the quantity of publications. Now, if you're lucky to find studies, many of them are of poor quality. This is linked to the level of research competency, but it is often also due to the fact that high-quality methods are difficult to implement in challenging settings. Both quantity and quality are directly linked to funding, and funds for research in low-middle income countries are very, very rare. An important fact is also, compared to and contrary to high-income settings, where most research originates from, low-middle income countries are way more diverse in terms of culture, geography, ethnic groups, economy, politics, history, etc. So even if there are some studies, usually they'll be from Rwanda, Cambodia, Nepal, they are not necessarily of help for what's going on in Haiti or Afghanistan or Niger. We cannot put the many contexts in one pot when we talk about research in low-middle income countries. Actually, what characterizes rehabilitation research in general? If you do a literature review on rehabilitation, again, three factors apply to the large majority of current publications. First, and mainly unmentioned because it's so common sense, research is carried out in established, functioning health systems. The examined health conditions are cancer, cardiovascular conditions, or various non-traumatic musculoskeletal conditions, such as low back pain, tennis elbow, disc hernia, or hip replacement. The research questions and aims are about what works best. So which timing, which duration, frequency, which combination of the many treatment modalities work best, with the aim of, for instance, shortest hospital bed occupancy or fastest route back to work and productivity. And now we'll move over to this woman in South Sudan. Let's assume she survived an armed attack to her home in a remote village in this gigantic country. She was lucky enough to get a medical evacuation by plane with an open tibia fracture. How can we use current rehabilitation research in the situation of this lady? You guess it, we can't. Current research is not helping. She doesn't have a condition we frequently find in high-quality publications, and the often sophisticated treatment modalities do not apply either. What does the woman need to become functional? She walks in a pair of cheap flip-flops. On her feet, you can see that she also walks barefoot a lot. She eats and drinks from a plastic cup, uses a pair of simple crutches, and she sleeps on the ground with a blanket. The surface on which she will have to move on is flat and sandy. As a matter of fact, therapy on daily life will not be complicated. There's an invigorating simplicity to how people in low-middle income settings live their lives. But most probably neither herself, nor her family, nor even hospital staff or ministries or health systems are aware of the added value and potential of rehabilitation. This is a story of lacks and resources, and it stands for the many stories in such settings. We tend to see the gaps first. The secret is about finding and using the resources to address the gaps. And the questions we need to ask are: what would research have to look like that's of service for this woman in Afghanistan, for instance? She's sitting on the ground, working on a sewing machine with her legs in ankle-foot orthoses. How can we build a body of research that reflects such realities? Conservative treatments requiring long hospital stays in overcrowded wards with lacking rehab infrastructure and workforce. Workforce. This map shows the number of physiotherapists per 10,000 population. We know that the prevalence of disability is significantly higher in low middle income countries due to health system challenges. So high needs for rehabilitation meet low supply, which leads to low awareness and vice versa. No or low supply of funds for workforce training, salaries, services, equipment, and for research. Now, the bad news is this is not going to change. The good news is that the future can only get better if we manage that mind shift to redesign and reinvent rehabilitation and research. The minimalist lifestyle of rehabilitation users asks for different approaches and models of care. Rehab research for and about low middle income countries must reflect and evaluate reality in low middle income countries and invent and suggest best practice for these settings. So it has to be planned with people living and working there, with patients, rehab professionals, and researchers on the ground. Rehab and research funding must be directly targeting such models. And optimal care in these countries is going to be about that. Simple and efficient ways of treating the most with the least in the best possible way. So I hope we can join efforts to design the future of rehabilitation research that is of use for the ever-rising numbers of persons in need of rehabilitation services in low middle income countries.